Thank you. Right. We are going to have a very nice presentation now. gvSIG applied to health by Professor Mercedes Rodriguez. She's a lecturer in geography at Las Palmas University, and Santiago Alonso, who is a doctor in the Canary Islands healthcare sector. He works in coordination planning and he has lots of experience. Good afternoon. First of all, I would like to say thank you to all the organizers for kindly inviting us to present our project, our work, which apparently is the first application of gvSIG to the healthcare sector. And hopefully it will not be the only experience in this field. I am a doctor, practitioner. My experience is in healthcare planning and management, and in cooperation matters. In fact, I've worked on cooperation in Mauritania. I will explain the general dimension of the project, and Mercedes, who is the expert in geography, will tackle more specific issues concerning mapping. I seem to have a problem with my PDF file. I cannot have the larger view. Sorry for that. But Mauritania is a developing country, but we did not start from scratch. The Mauritanian government already had some level of infrastructure and wished to take such healthcare infrastructures closer to the population. The deployment of the system, of the health system, was a little bit chaotic in Mauritania and really varied with ups and downs depending on the government on power. Mauritania is still a very tribal country, and so if the Minister for Health comes from this or that other tribe, work fluctuates greatly. But lately, the tribe minister sort of wanted to foster healthcare matters more evenly, because the situation was very, very uneven in the country. Right, our project is part of the medical efforts on a voluntary basis made by Spain in this African country. We carried out an analysis at the beginning to be able to have a diagnostic of health in Mauritania. First of all, we analyzed all healthcare plans deployed in the area to date, and we also came up with a diagnostics on the Ministry of Health of Mauritania to see if it was worth our while to work with this department, with this ministry, or to transfer our work to other areas such as education. The results confirmed that it was necessary to continue investing in the healthcare system in Mauritania, and so a number of projects were launched based on the country's priorities, and one of those first projects was what we call the healthcare map of Mauritania, funded by the Ministry of Health of Spain. The goal was to prepare a health map to try and meet health demands with health supply. Mauritania does not only rely on the Ministry for Health. A lot of work is done by NGOs in the country, and so things had to be complemented to avoid duplicity. The health map was considered to be a very powerful tool to support decision making and try to combat wrong political decisions made by this or that minister. It was a way of giving tools to objectively make decisions and prove in front of the authorities which projects were more convenient and covered a greater share of the population. So a lot was done by Spain and voluntary organizations in Spain. What's the aim of the map, of the health map? Well, the main objective was to draw a map to take a snapshot of existing healthcare infrastructures, not only find out their location or find their location, but also to try and analyze the existing infrastructure by means of a questionnaire to try and determine whether the healthcare center was okay, if it had the necessary staff, the necessary equipment, the services to be supplied to the population, and so be able to adapt the services to the population's epidemiological profile. So basically to determine all these aspects with a diagnosis within the framework of the map. So as I said, it was a snapshot of existing infrastructures and what they did and with what resources. When the project was started, the diagnostic was launched and the project was then formulated and structured into 3 phases. Phase 1, the pilot survey. In this case, we had to go to all healthcare infrastructures and produce tools to collect information. The tool was a questionnaire, a survey. We prepared a questionnaire with a manual for those who were to administer it and for these people to collect the information. We trained the interviewers in detail to be able for them to do it. We then administered the survey, and then questionnaires or the surveys were validated and data were verified to try and fine-tune the system, the questionnaire. And then the data collected were analyzed. Once all these actions were taken, phase 2 started with a national scope. The participants in the national survey were trained, and we followed the same procedure. Data were collected and then analyzed for the map to be produced. The map was not the ultimate goal of the project. In fact, the map was a tool, is a tool in the project. And we now come to phase 3, planning or replanning of the healthcare services in Mauritania. Let me explain the phases in more detail. Phase 1, pilot survey. It was developed from July to September 2012. The survey aimed to validate answers and data and to identify problems to improve things for phase 2, for the national survey. As I said, the staff were trained and it included 100 people. To select the geographical areas for the pilot questionnaire, a number of provinces were selected. Mauritania is a huge country, and therefore we tried to include regions which did not pose too high costs. We did not want to go too far because, as I said, distances are tremendously huge. We selected 30 towns, 30 municipalities, 96 public healthcare infrastructures or centers, accounting for 20% of the total, which was not a lot, only 3.2%, but the population covered was quite high, 16%. These are the geographic areas selected for the pilot survey, which met the criteria that I just mentioned. In Nacho, we chose 3 nagatas or municipalities, or 3 districts: Tebraseina, Tersja and Dizertin. And then in the north, we chose an area which combined different infrastructures, including a hospital and a private company, private healthcare company, and other institutions such as workers' hospitals to attain more representation. And we also selected towns from other more densely populated areas, and which also pooled or concentrated patients from more remote areas. In Butilimi, in fact, in Butilimi, there was a hospital run by an NGO, which was interesting for the sample. So more or less these were the criteria and the pilot areas. You see a few photographs with the training for phase 1. What are the results of phase 2? Well, some difficulties were encountered, as we suspected, which forced us to change the wording of some questions, because some questions were not accurately understood in the preliminary questionnaire. So based on the identification of these issues, we amended the questionnaire. We also found a mistake in transferring things from paper to a digitalized file. The computer people working in the field noticed things did not match exactly on Google Map. So they individually adjusted each coordinate to match things perfectly, and when that was entered in gvSIG, the whole band of the Senegal River were moved to Senegal instead of Mauritania. This is a bit of a story, of a funny story, but anyway. The most interesting thing about phase 1 is the fact that we identified mistakes and faults in the systems, and we managed to improve things. Sometimes there were mismatches between, questions and answers, but we did manage to overcome this by delivering further training. When data were entered into the system, some variable codes were changed, and therefore that caused mismatches, and so the tables have to be renamed and recoded. Or other problems, the person from the ministry would enter new variables which were not foreseen in the questionnaire, and they were entered without observing the logic in the questionnaire, the logic in the questions, which obviously took into account a lot of elements. It was a logical sequence, so sometimes civil servants from the ministry would enter their own variables without observing that logic. And then they would use their own codes for the denomination of villages, towns or provinces, which were not the official codes of the country. The ministry seemed to have their own coding, and so they entered it into the questionnaire. And finally, in spite of our insistence on the coding of the epidemiological profile, it was not observed on some occasions. Right after the pilot phase number 2 was started, training was delivered to the interviewers. Supervisors were trained too. All the questionnaires were checked and verified to avoid consistency issues in the answers. This was done from October to November 2012, and 3 people teams went to the areas with a higher concentration of healthcare facilities and centers, and 2 people teams were arranged as well for those areas with less infrastructures. 11 vehicles were provided for 45 days, though in some specific cases the period had to be extended for 2 complete weeks. A few photographs of phase 2, the training session for the national survey. What was the result of the national survey? Well, the questionnaire was administered in 1,533 healthcare facilities, including 581 health organizations, centers, 81 healthcare centers, 18 general hospitals, 3 specialized hospitals, 5 healthcare schools, and 845 private structures. Initially, these private structures were not included in the project, but the health ministry wanted to know how many health providers existed in the country, because there was no control whatsoever. In Mauritania, you can set up your own practice. You don't need to register with any association or organization. Nothing was regulated. So on the occasion of the survey, the ministry told us they wanted to know how many private centers or practices existed, for them to have a broader picture of the situation. Most of these practices were in the capital of the country, obviously for profitability reasons. That information on the private structures was not entered into the system, though, but the information was given to the government. Okay, results and analysis, right? The survey was administered in the last term in 2012. Data, the way they arrived to us were so chaotic. Variables did not match the fields, the other way around. So a lot of fine work had to be done, record by record, for all the infrastructures to try and correct the mistakes. All the mistakes were sent to the officials and then corrected. A lot of work was done, as I said, and quite a few records were missed. Let me explain. A lot of information was not entered into the survey for a number of reasons, unfortunately. Right, based on all the information, the health map was produced. In this case, we must mention the mapping layer, the maps, which was given to us by the Geographic Institute of Mauritania, and then the population records. In fact, when we were there, the population census, the rolls were being collected and produced, and all this information was not yet completed when we were there. So we did not know how many children, for instance, under 5 were part of the population, or women, of a fertile age, and all these things, which is very important to accurately plan healthcare services. Okay, I'll give the floor to my colleague now. Over to you. Yes, the existing situation in the country had to be known and reflected on a map. 85–90% of our geographic information system lies in the quality of the data. That's why we had to take great care in verifying absolutely everything. This is an example of how data were collected, and in fact you had these funny results. For instance, there is a health center here right in the middle of the sea. So the government did not want to have a static map, but a dynamic one with lots of information. Therefore, we thought the use of a GIS was absolutely essential. The big problem was, well, obviously a GIS system, because it met the criteria of a quality map. What were the problems we encountered? Well, first of all, to decide which GIS system. They knew a few systems in the country, but they were a bit too expensive for them. Other proposals were put forward, Enigma by the World Health Organization, but these projects had run out of funding, so they could not be used. Following the advice of different experts, and well, gvSIG was not known in the country at the time. There was no previous experience in health either. But yeah, we did not know GVS for health purposes, but we did know the project gvSIG, and we decided to go for it. The project of the health map has different layers. Some of them are common, consisting of road information, healthcare information, flooded areas. All this information was provided by the Statistics National Office and the Spanish Cooperation Agency. And then there were specific layers which were produced on the basis of the data collected in the survey. Coordinates were taken by GPS. Well, imagine, how difficult it was. It was because people had very basic training just on GPS systems, etc. And then, the training was delivered, and we then finally had the right coordinates to work with gvSIG. We also had layers for the catchment areas health-wise, and this was very important. Catchment areas were considered to be 5-kilometer radius areas from a healthcare center, 5 kilometers, and tabular data together or linked to each variable. gvSIG version 1.11 was used because we did not have 1.12 available yet, so we used this one. Each healthcare unit was given a symbol produced by ourselves. These symbols show the functionality level of the center. As you can see, it could be checked or not checked. And then hospitals had other symbols, etc., etc. This is the layout of our project, specific layers for each infrastructure and a general one for all infrastructures. The general layer allowed us to identify all healthcare centers in the territory. This is a view of the project, of the map project. It has 5 sector views and one which is more general. Let's move on. We have general layers, hospitals, and the cartographic map or basis, as we call it. And then, as I said, specific layers with health schools, hospitals, specialized hospitals, private practices, etc. This is the capital of the country, Mogadishu, including all the flooded areas or floodable areas. This is another view with the layers. This is the view for the hospitals and for the health schools. And here we have another view. And an important thing. We could work with different scales, which was very interesting for us. And we have more formats. This format, for instance, for everyday work, and another format for gvSIG.
This is the project, and this is a view with all the infrastructures. Here we have the southern area of the country. In red, all the areas we are in the influence area, and then all those points are populations without any healthcare coverage, primary healthcare, and that was a good contribution to our project, and that allows you to organize the services. So other important issues was to make a training for all the people that were going to work in the project. That was done together with us, and we distributed 80 hours with more or less 45 people in a room with information technology equipment, and then the applications we did were based on the healthcare map that was done in French, which is the official language of the country. And many of the doubts that we had during the project were resolved during the forum. We designed this for the course in order to use the program of the gvSIG, people working in the project with their maps down there. And here we have other views. And finally, the map was a main tool for the redistribution of the resources in order to establish priority areas for intervention in order to improve the management of the needs for health care. And the use of the program allowed the creation of this system that would have not been possible without the existence of this program. We train people in gvSIG, and that saved a lot of economic resources to the project, and it was a new experience in the country. gvSIG had never been used there, but in the country we see that this system was not used before, and then we have also studies in geography and health that didn't exist before. Sorry for this